Hello, I'm Dr. Anil Goody, consultant in reproductive medicine and surgery at the Homerton Fertility Centre, London. This is a slightly different case of an endometrioma in assisted conception. 28-year-old woman with a failed ICSI cycle. In 2016, she had an endometrioma that was treated. January 2018, a 4 centimeter left-sided endometrioma was treated again, and a hydrosalpinx clipped. ICSI was done. 3 8-cell embryos were replaced. The test was negative. Following which, a Dynogest was given for 2 months, and 4 centimeter cysts still remain. Her AMH is 4.41 nanogram per liter, AFC of 6+6. What treatment should be done? Should we aspirate or should we go for another surgery? It's an interesting case because you have somebody who has got aggressive recurrence of endometriomas. I don't know how the treatment would have occurred. If it is fulguration, the recurrence rates are higher. 25% of aspirations with fulguration have a recurrence rate. Stripping has a lower recurrence rate. Again, stripping causes more damage to the antral follicle count. Endometriosis itself causes more damage to the antral follicle count. Have a look at the 2018 article just published in Fertility Sterility called Error on endometriomas, and endometriomas themselves cause a lower antral follicle count and lower AMH. Removing them and stripping the base wall takes away normal ovarian tissue. If you see, this woman already has a surgery done in 2016. She has a surgery done in 2018. What do we do in this case? One of the things that I will always tell my trainees and others is when you do surgery for endometrioma, your job should be, outside fertility, is to lower the risk of recurrence. And how do you do it? There are multiple ways of doing it, either by ovarian suppression or by pituitary hypothalamic suppression, or using the Mirena, or using progesterone. But some way that you prevent a recurrence of the cyst pending fertility treatment. But that is something which is a different topic altogether, and there are various methods where you can lower the chance of an endometrioma recurring. But there are some cases where you just cannot but see a recurrence of endometrioma, one after another. And often we see repeated surgeries, even with extremely proficient surgeons, leading to a decline in the antral follicle count and eventually to AMH. If you see the works done by Jack Donnet, where he beautifully gives all these studies which show that aggressive treatment of endometrioma will often lower your ovarian reserve. This is again a difficult choice. Now, have a look at the image upstairs. If you have a look, there are some endometriomas who have a large cyst with a good antral follicle count. There are others who have a cyst with a very thin antral follicle count. Have a look at, irrespective of AMH, have a look at the picture. Those with a better antral follicle count, a larger component of ovarian tissue left behind, will give you a much better chance of stimulation. Equally, if you were to do surgery with fulguration, I would not ask you to strip the cyst wall prior to an IVF cycle. Then in those cases, this ovary does better. On the other hand, have a look at the second slide. That cycle is a cyst where the follicle count is very, very small and the amount of ovarian tissue is very thin. Any aggressive surgery will push these patients to be into a very poor reserve and eventually a poor responder. So what do we do in this case? And I think if you have two cysts of 4 centimeter, if they're on either side, you have two options. Often I tend to say, let's start stimulation. What do I gain by aspirating this cyst? It will fill up with stimulation again. If you do it transvaginally, the fluid is so thick that you'll have to flush those follicles, increasing the chance of infection. If you do another laparoscopy, it's going to delay her IVF treatment. And often I would say, let's start stimulation. Do you use a long protocol? Don't. Use an antagonist protocol. I don't know what dose you should give her, but the AMH being decent, antral follicle count being fine, anything between 150 to 225 should elicit a good response. Collect the eggs. If need be, do 2 cycles. Collect the embryos. Get them to a blastocyst stage. Do not do day 3 transfers. By doing day 3 transfers, we are not getting those answers whether these embryos can reach a blastocyst stage. The simple question is, does endometriosis affect oocyte quality? And the answer is yes, it does. Putting them on a long protocol, in fact, reduces the antral follicle count. Don't put them on a long protocol. Put them on the antagonist protocol. Use a slightly milder stimulation. Move the dose according to how the response occurs. Collect embryos. The antagonist cycles allows you to do 2 cycles and collect the embryos and freeze them. If you've got 3 to 4 blastocysts, then focus on the endometriosis. Then suppress the ovary, suppress the endometrium. Between 2 and 3 analog injections, and then replace the embryos. You're more likely to get a better response. I do a lot of endometriosis surgery. I do a significant amount of which is lateral pelvic wall dissection and ureterolysis. But there is a place for surgery in reproductive medicine and surgery too. Surgery for pain requires more aggressive surgery. Surgery for fertility requires a more cautious approach. Retaining the antral follicle count, retaining her AMH is paramount. Have an AMH before you operate. Medico-legally, that is of essence, but also it tells you in beautiful words, terms, what is that reserve? What is the expendable reserve that can be present? Your scanning will give you a much better idea of the depth of your antral follicle count and the depth of the theca. Very important things. Something which you'll learn a lot more in the next couple of weeks. Thank you very much. Bye-bye.